Good afternoon, everyone, and welcome to the CCR by the Medicine Unit 2. Fever is the most common symptom that we come across in medicine, and often it may be difficult to diagnose or difficult to treat. So, we present an interesting case of relapsing fever in front of you. The case will be discussed by Dr. Rohan, junior resident, and the review of literature will be discussed by Dr. Karthik. So, over to you.
Thank you very much, sir. Very good afternoon to one and all present here today, respected faculty, my fellow colleagues. Today we'll be talking about an interesting case of relapsing fever. Case begins with that of a 37-year-old gentleman who was a resident of Sikandrabad, Uttar Pradesh, without prior comorbidities. He was a construction worker, married with 3 children, and who is right-handed. He came with the chief complaints of lower limb weakness with lower backache for 1 month, tingling and numbness in both lower limbs for 1 month, and double vision for 1 month. Now, his lower limb weakness with lower backache was insidious in onset, initially localized to both of his thighs, progressed to involve the whole limb over the course of a month, and he became bedbound since 1 week. His symptoms were more on the right side. They were associated with dull aching and diffuse lower backache. He also had a history of 2 kg loss of weight present in 1 month. There was tingling and numbness present in both the lower limbs, which were insidious in onset, initially localized only to both of the feet, but they progressed to involve the whole limb over the course of a month. The symptoms again go more on the right side. With this, the patient had double vision, which was insidious in onset, gradually progressive, more on looking towards the right side. There was no diminution of vision or restriction of eye movements. Now, there was no history of bowel or bladder incontinence, fever, diarrhea, recent immunization, cough with expectoration, loss of appetite, history of tuberculosis or contact with the patient or tuberculosis. The patient did not have any prior comorbidities, and in his personal history, he was married since 2008 with 3 children. He had normal bladder and bowel habits. Only social alcohol use was present, and there were no high-risk features present. Now, I would like to go and give a brief background history of this patient. From February 2021 to November of 2022, he repeatedly presented to an outside clinic with intermittent episodes of loose stools. This was for a duration of 1.5 years, with on and off fever with chills, with spikes of 102 to 103 degrees Fahrenheit for a duration of 1 year. He received multiple antibiotics. However, there was only transient resolution of his complaints. In November of 2022, he presented to our medicine OPD at AIIMS New Delhi with on and off fever of low grade for 1.5 years, intermittent episodes of loose stools for 1.5 years. He was evaluated from an outside hospital and was found to have hepatosplenomegaly with pancytopenia, for which a bone marrow was performed. This showed that there was presence of pancytopenia with AG reversal with increased globulin fraction. His radiology revealed the presence of hepatosplenomegaly. His bone marrow revealed tri-lineage hematopoiesis with the presence of intracellular as well as extracellular LD bodies. On his investigations, his RK39 was positive. We diagnosed him as a case of visceral leishmaniasis and as per guidelines gave him a single dose of liposomal amphotericin B 10 mg per kg. He was kept in close follow-up of the infectious diseases clinic. He was symptomatically better and his cytopenias were on the improving trend as seen in the December slide. In January of 2023, however, there was recurrence of the symptoms. He had loose stools mixed with blood and mucus. There was loss of weight of 3 kilograms in 2 weeks, as well as loss of appetite. We checked his investigations. There was presence of pancytopenia with persistence of his AG reversal with increased inflammatory markers. At this point of time, we had kept the differentials as relapse of visceral leishmaniasis, and we had kept another differential of gastrointestinal tuberculosis. We also had kept the differentials of gastrointestinal histoplasmosis with PL-HIV with MAC by cryptosporidosis as our differential diagnosis. On radiology, there was presence of persistence of hepatosplenomegaly. His bone marrow examination revealed tri-lineage hematopoiesis with reactive plasmacytosis with hemophagocytosis and the presence of LD bodies. A CT enterography was performed, which revealed multiple enlarged, non-necrotic, non-conglomerated nodes, along with diffuse circumferential wall thickening in the colon. He was diagnosed as a case of relapse of visceral leishmaniasis. He received liposomal amphotericin B in 40 mg per kg in divided doses. He was kept in follow-up and there was presence of resolving cytopenias. The patient once again came in May of 2023 with the complaints of recurrence of his fever with new onset swellings in the neck region. His neck examination revealed multiple bilateral cervical lymph nodes along with the presence of multiple bilateral axillary lymph nodes. On his lab investigation, there was once again persistence of his pancytopenia with an increase in his inflammatory markers. The CD4 count was also sent at this point of time, which was 391 cells per microliter, and his LDH was normal. At this point of time, we kept the differential diagnosis as lymph node tuberculosis along with lymphoma. An FNAC was performed of his axillary lymph node, which revealed the presence of numerous histiocytes with LD bodies. There was no evidence of lymphoma or any granuloma present. This was suggestive of a relapse of visceral leishmaniasis with lymphadenopathy. He received liposomal amphotericin B 4 mg per kg for 5 days with 5 weekly doses for a net dose of 40 mg per kg. Along with this, he received capsule miltefosine 50 mg BD for 4 weeks. Till now, we have seen that the patient in Feb 2021 to November 2022 had visceral with gastrointestinal leishmaniasis. In January of 2023, he had a relapse of his visceral leishmaniasis. And in May of 2023, he had relapse of his visceral leishmaniasis with a lymph node involvement. Cut forward to what happened between May 2023 to November 2023, he was kept on monthly suppression therapy of liposomal amphotericin B at 4 mg per kg. He was asymptomatic. He gained 12 kgs of weight. There was resolution of his cytopenias as well as reduction in his hepatosplenomegaly. In November 2023, he once again presented with weakness, tingling numbness in both lower limbs, and double vision. Now, with this history, we took him forward for examination. He was conscious, oriented to time, place, and person. He was vitally stable, afebrile. There was pallor presence with bilateral cervical, axillary, inguinal lymphadenopathy without icterus, cyanosis, clubbing, or edema. On his skin examination, there was presence of multiple papules and nodules which were noted on his face and his neck. CNS examination, he was conscious, oriented to time, place, and person. Cranial nerve examination revealed limited abduction of right eye with right eye esotropia. On CNS examination, there was wasting present in both of his lower limbs. There was hypotonia of the lower limbs on both sides. Power was reduced bilaterally, it was 0/5. His deep tendon reflexes, plantar reflexes were mute, and his knee and ankle reflexes were absent. All sensations of the lower limb were reduced. However, the upper limbs were not affected. Spine there was no significant spinal tenderness which was noted. To summarize the case till now, we have a 34-year-old gentleman with asymmetric onset, sensory motor, lower motor neuron type of paraparesis, proximal more than distal, without bowel and bladder involvement, with right lateral rectus palsy, localizing it to the cauda equina region with the right-sided sixth nerve palsy. We performed some investigations. The CSF parameters revealed an increase in cell count with predominant polymorphonuclear cells. And his CSF protein was elevated. It was 721 milligram per deciliter. On his investigations, his CD4 count was 256 cells per microliter. His serum RK39 was positive. Urine histoplasma antigen was negative. And there was absence of hepatosplenomegaly on ultrasound. At this point of time, we had kept the differential diagnosis as tuberculosis with spinal involvement, disseminated histoplasmosis, and relapse of visceral leishmaniasis with lymph node involvement. I would like to call my colleague, Dr. Mohak, for further explanation of this.
Good afternoon, everyone. So these are the T1 weighted, T2 weighted, and post-contrast sagittal images of the same patient, MR of the spine. And these are the axial T2 and the post-contrast T1 weighted images. So on the post-contrast images, we can see this nodular kind of leptomeningeal enhancement along the dorsal spinal cord as well as the conus medullaris. And in these T2 weighted images, we see the thickening of the nerve roots at the level of the filum terminal and the cauda equina, which is showing post-contrast enhancement also. So these findings are in favor of arachnoiditis. Then these are the top panel is the pre-contrast and the lower panel are the post-contrast FLAIR images of the same patient. And here we see that there is nodular thickening and enhancement along the bilateral trigeminal nerves, right more than the left side. And in these SAG images, we see some nodular enhancement and thickening of the right abducens nerve as well, which could explain the diplopia of the patient.
Thank you, Dr. Mohak. Now I would like to call my colleague from nuclear medicine, Dr. Yami, for further explanation of this.
Good afternoon, everyone. The PET-CT images of the patient shows diffusely increased FDG uptake in the spleen and the mid-image, along with multiple FDG-heavy, non-necrotic, discrete, cervical, axillary, mediastinal, retroperitoneal, and inguinal lymph nodes, with with increased FDG uptake in the spinal cord, with involvement of the meninges from D10 to S1 vertebrae, along with the FDG-heavy subcutaneous nodule in the left lateral thoracic wall. Based on the above mentioned stand findings, the first possible differential of residual active disease was given. The second possible differential of sarcoidosis, including neurosarcoidosis, was given in view of lambda sign and neural involvement. And the final diagnosis of lymphoma was included based on splenic hypermetabolism and multiple lymphomas and residual active disease. Residual active disease, because we knew that the case.
Thank you, Dr. Yami. Now we performed an FNAC of the lymph node, in which there was presence of intracellular LD bodies with reactive lymphocytes in the submental lymph node. An axillary lymph node biopsy was performed, which revealed the presence of few LD bodies, but there was no evidence of lymphoma or any granulomas. Skin biopsy was suggestive of granulomatous dermatitis, and bone marrow was performed, which had tri-lineage hematopoiesis with occasional LD bodies. Now, coming back to our differential diagnosis, we had ruled out tuberculosis with spinal involvement, because there was no presence of CSF gene expert. Disseminated histoplasmosis was also ruled out on the basis of absence of hepatosplenomegaly, and urine histoplasma antigen was negative. We had kept the differential of relapse of visceral leishmaniasis with lymph node involvement. At this point of time, we had presumed that a single diagnosis, a single unifying diagnosis could explain all of the presentation that this patient has been having. Since the past, he has had multiple episodes of relapse of visceral leishmaniasis. Along with this, he has had GI as well as lymph node involvement. We performed a PCR of his CSF, a lymph node, the submental group, as well as a subcutaneous skin nodule on the left side of his chest in the 6th intercostal space. All of these had positive results, and the genome sequencing also confirmed that it was Leishmania donovani at ITS1 locus. We made the diagnosis as neuroleishmaniasis with cranial nerve involvement of the right 6th side, arachnoiditis with cauda equina syndrome, visceral leishmaniasis relapse, and lymph node involvement. He received liposomal amphotericin B 10 mg per kg per day for 3 weeks, followed by 5 mg per kg per day for 5 weeks. He received capsule miltefosine 50 mg BD for 8 weeks, and with this, he received weekly intrathecal hyaluronidase 1500 units with a total dose of 12 doses. The clinical outcome was that there was resolution of right eye deviation after 4 weeks of therapy, gradual improvement in lower limb weakness, which started from 4 weeks of treatment, and this was 1 week after initiation of intrathecal hyaluronidase. After 8 weeks of treatment, his lower limb power increased to 4 minus by 5, and on discharge, he could walk with support with a power of 4 plus by 5. His repeat CSF leishmania cell-free DNA PCR was negative. He was kept on 10 milligram per kg liposomal amphotericin B weekly suppression therapy after his discharge. We had now wondered as to why he had repeated episodes of leishmaniasis. Was there an underlying immunodeficiency disorder? His repeat CD4 count was 503 cells per microliter, and his PID workup, however, it did not reveal any abnormality, for which we performed a whole exome sequencing, which revealed the presence of an IL-12 receptor beta 2 subunit heterozygous mutation. Now, to confirm whether it was a functional mutation, we had performed a CD3 stimulation as well as CD14 stimulation. However, this did not reveal any new abnormality. We made a final diagnosis of visceral leishmaniasis with multiple relapse in the form of gastrointestinal involvement, lymph node involvement, neurological involvement in the form of cranial nerve 6th right side, spinal arachnoiditis with Cauda equina syndrome, and IL-12 receptor beta 2 subunit heterozygous mutation of query significance. Now I'd like to call my colleague, Dr. Karthik, for further discussion.
Thank you, Rohan. We'll continue our presentation. There are atypical presentation in visceral leishmaniasis, which can involve multiple organs, GI involvement leading to esophageal and chronic diarrhea, malabsorptions. It can even present with a lymphadenopathy, can involve laryngeal, pleural, pericardial, and neurological manifestations can present as a meningitis, neuropathy. It can involve the renal, adrenal gland. There are atypical skin lesions which can can mimic the PKDL. It can even present like a hemophagocytic lymphohistiocytosis and aplastic anemia. These manifestations are more common in immunocompromised individuals. It can lead to diagnostic dilemma in the treating physicians. There are only 11 cases of Indian visceral leishmaniasis have been reported with lymphadenopathy. 7 out of 11 cases had VLHAV co-infections. All the reported cases demonstrated LD bodies in lymph node biopsy or FNAC. Gastrointestinal leishmaniasis in India is mostly reported in VLHAV co-infections, and only 4 cases have been reported in HIV negative individuals. The common clinical presentation is fever with chronic diarrhea for 6 months to 2 years. The imaging findings usually show the thickening of the colon and multiple sites, and the endoscopy show the multiple ulcers. The biopsy of all the cases have shown chronic inflammatory cells in the lamina propria with LD bodies. The neurological manifestations of visceral leishmaniasis can involve the PNS or the CNS. In CNS, it can manifest as the multiple cranial palsies, tremors, myoclonic movements, meningitis, spinal arachnoiditis, and Cauda equina syndrome. Only there are 6 cases have been reported with CNS involvement in visceral leishmaniasis, and they have a varied clinical manifestations like headache, hypotonia, seizures, meningitis, tremors, and reduced consciousness. To date, there is no data on the CSF picture of the neuroleishmaniasis is available. Similarly, no data on the specific imaging features is available. So there are only 2 case reports which have mentioned the neurological imaging. These are very non-specific in pertaining to the neuroleishmaniasis. So till now, we haven't get much guidance from reviewing the literature on managing such a case with multiple atypical presentations and multiple relapses. So the relapse, most commonly relapse occurs in 6 to 12 months following the treatment, and the relapse estimate following single dose of liposomal amphotericin is 4.5%, and liposomal combination therapy is 1.5%. The risk factors for relapse in non-HIV individuals include male sex, age less than 5 years or more than equal to 45 years, slower decrease in splenomegaly, shorter duration of symptoms. Apart from this, there are multiple predisposing conditions which include transplant-related immunosuppression, TNF-alpha inhibitors, steroids, malignancies and related chemotherapy, IL-12 pathway disorder. Till now, there are 3 case reports which have mentioned there are multiple relapses in individuals who have defect in the IL-12 pathway. On reviewing the management, VLHAV co-infection has a lower efficacy and higher relapse rate following the treatment, and moreover, there are insufficient data on other immunocompromised hosts with malignancies or post-transplant or those on immunosuppression due to various other reasons. Now, how to manage relapse? IDSA recommend to give high-dose liposomal amphotericin for a longer duration. or any alternative drug with combination therapies. In vitro studies have showed that liposomal amphotericin along with the multifosin combination is synergistic. Moreover, like multifosin exhibits immunomodulatory properties and it promotes Th1 response. Recent RCT have also shown that it achieves 97% relapse-free survival. So this combination with liposomal amphotericin along with the multifosin would be effective in managing the relapse. Apart from this, there is a significant role of intrathecal hyaluronidase in case of spinal arachnoiditis. Hyaluronidase breaks down the extracellular matrix and prevents the organization of the exudates. Multiple case reports have showed its benefit in tubercular optochiasmatic arachnoiditis and spinal arachnoiditis. Even in our patients, significant improvement in the lower limb power has been noted after intrathecal hyaluronidase. Finally, take-home points from our presentation are visceral leishmaniasis may present atypically in immunosuppressed. Relapse is not uncommon in immunosuppressed individuals without HIV. Combination therapy with liposomal amphotericin and multifosin is effective in the management. Thorough evaluation of immunodeficiency disorder is needed for relapsed individuals. Thank you. I would like to call Professor Manisha for comments.
So the reason for bringing this case are twofold. One, it is sort of a forgotten disease or less thought of disease. When as a resident, we used to suspect this in all cases of PO, and this was sent in all patients on OPD basis, the RK39. And at all times, we had patients admitted in the ward, and most of them would turn out to be PL-HIV. So this HIV, visceral leishmaniasis, this symbiotic relationship. So now it has decreased since the rollout of ART since 2005 and much better disease control in PL-HIV. We are seeing a lot less of visceral leishmaniasis these days. But however, this patient was HIV negative. One CD4 I think was missing. One CD4 was around 250 to begin with. But we couldn't label him as idiopathic CD4 lymphopenia because subsequently the counts have increased. Now it's above 500. So now he has so many atypical manifestations which are all limited to case reports in a single individual happening. A GI involvement, a lymph node involvement, a neurological involvement. The challenges of treatment were multifold. All said and done, miltefosine is a very good add-on therapy, but its CNS penetration is very, very poor. So probably that's why this patient required a very long course of amphotericin B of 8 weeks at high doses, along with hyaluronidase, which really worked to improve his muscle power. So now that what we are left with is a very challenging situation. How long to give secondary prophylaxis in this patient? He already was on prophylaxis at a low dose of liposomal amphotericin B when he developed this third relapse, fourth episode of leishmaniasis. So currently we have completed 12 doses. Previously we were giving monthly doses. Now we are giving weekly doses. We are basically extrapolating from our experience in HIV, PL-HIV, when where this secondary prophylaxis has been used. But there is a mark that CD4 count is a proxy. So it is usually given until CD4 count goes above 350. So this patient now has crossed, just now the last report has crossed 500. So we will take a call how long to continue the secondary prophylaxis in this patient for leishmaniasis. So any experience, any comments, suggestions, please.
Where to get the miltefosine?
Miltefosine, we first Safdarjung, they have a supply there. वहाँ से आया था. Then NVBTCP. So we directly contacted the program people to supply it. Yes. So it's not available in the market. Yeah. Yes. So we actually contacted the NVBTCP directly to arrange this. So to be frank, we don't know what is the immune suppression here, IL-12 receptor, but functionally it is fine. So what we will go with probably is CD4 counts, which at the lowest point was 250. We initially did keep a possibility of idiopathic CD4 lymphopenia, but subsequently counts came 350, and day before only I think it's 500. So we will take a call on that. No other prophylaxis above 300 CD4 that would be my take on it.
Any home infection.
Yes, so that is a strong pointer against this mutation because there are no other infections which have been happening in this patient. Yeah, exactly. Yes. Yes. So there. Yeah. So this PCR thing we got it done from through ICMR. So there are studies which are now looking at PCR as a relapse measure among PLHIV. They are comparing it with whether to stop with a CD4 350 or should stop when PCR is negative. So those things are ongoing. So that is again an option that we will see. Yes. Yes, quite likely. That's why we didn't mention anywhere idiopathic CD4. It's likely due to that also. That's why we didn't mention anywhere in the right.